Wow. I've seen that video a couple of times, and I still have a hard time watching it with dry eyes. How inspirational is that to see the looks on the faces of those children, even in recovery, who are opening their eyes and looking around and seeing the world in front of them for the first time or for the first time clearly. It is truly inspirational. Now it's my pleasure to announce our next speaker, long-term Orbis volunteer surgeon and my father-in-law, Dr. Bradley Black. Thank you.
Thank you, Faye. See where I can, is that the remote? Right there? Good, let me use that. Thank you. Let's see, there we go. Some of these numbers you'll hear again that have already been mentioned in the video and by Jack. The World Health Organization estimates that there are 39 million people in the world who are blind, and another 246 million who are visually impaired. 90% of those people live in developing countries, and 80% of that blindness is either preventable or curable. 19 million children are visually impaired in the world, with 1.4 million irreversibly blind. The majority of these children develop their blindness before 5 years of age, and there's a very high mortality rate in this group, often because of the diseases that may have caused the blindness may also threaten that child's life. Blindness in the developing world carries a very high social, economic, and quality of life cost. If a mother of a family becomes blind, very often her daughters will quit school and take on family responsibilities that would have been their mother's responsibility. That loss of education often results in a loss of opportunity for breaking a cycle of poverty. Much blindness in the world is caused by fairly simple diseases: measles, rubella, vitamin A deficiency, damage from traditional healthcare methods. And in some areas of the world, those problems have become less common because of immunization programs, vitamin supplementation, and education. But much of the blindness in the world is the result of diseases that require much more sophisticated diagnostic and treatment methods, including surgery. And the barriers to being able to treat this in the developing world are lack of resources, but probably more important, a lack of skilled eye surgeons in the developing world. Many North American ophthalmologists travel to developing countries to do surgery, but unfortunately, this only puts a little dent into those statistics that we're looking at. So the Orbis goal has been to teach modern surgery to ophthalmologists in developing countries, and then have those doctors teach those same procedures to their colleagues, so that the student becomes the teacher. We network this to where eventually we have an adequate number of skilled eye surgeons in a developing country. The Orbis idea began with David Payton, an ophthalmologist in Houston, and the development of Orbis was spearheaded by Al Ulci, who remained as the chairman of Orbis for many years. Orbis performed its first program in 1982 on the DC-8. My first Orbis mission was in 1988 in Khartoum, Sudan, and most recently I was on the plane about 6 weeks ago in Da Nang, Vietnam. This is a picture of the DC-8 in 1989 in Papua New Guinea. In 1994, the DC-10 replaced the DC-8, and this is the plane that we currently work on. And as Jack has shown you, we're eagerly anticipating the arrival of the new plane. Orbis is certainly, the brand of Orbis is with the Flying Eye Hospital. It's certainly best known for that, but as Jack pointed out, there are many other programs that Orbis sponsors. Hospital-based programs are usually done with a small team of 4 or 5 professionals, ophthalmologists, nurses, anesthesia, and these may address different ophthalmology subspecialties: nursing, pediatric anesthesia, eye banking, biomedical engineering. And so even though the plane may not be able to go to a country frequently, we can fill in some of those gaps with hospital-based programs, either ahead of the plane or after it is no longer visiting that country. ORBIS CyberSite Telemedicine is a internet-based telemedicine program. Doctors in developing countries can communicate with mentors in North America so they can discuss difficult cases. We can talk back and forth about that. There's a large amount of curriculum material on there. They have access to journals, textbooks, continuing medical education. ORBIS has a significant presence in many countries, and in some of those has a country office that helps coordinate these programs in that country. So when I go out on ORBIS, I go as a visiting faculty in pediatric ophthalmology. And when we have a program that's on the plane, the first day we'll work in the local hospital where, along with the host ophthalmologist, I'll examine patients that day. We can discuss the problems, and we can choose people that we're going to do surgery on through the rest of the week. The DC-10 contains a modern operating room with very sophisticated audio-visual equipment, so we can broadcast this surgery into the classroom and to other monitors around the plane. I wear a microphone on my mask so that we can narrate the procedure as we go along and discuss it with the classroom and answer questions in real time as we're doing the procedure. As it was mentioned, there are 48 seats in the classroom on the DC-10. I've been on programs where we've run remote classrooms into the airport and had as many as 250 doctors participate in the program. So the networking and the teaching that goes on can be pretty extensive. We also go into the local hospital during the same week because, and this is very important because it gives us a chance to look at the supplies and the equipment that our host doctors have in their own hospital. And we can tailor the procedures that we're teaching and that they're going to be doing to where it's tailored a little bit better to what's their situation in their local hospital. It also gives us an idea of what supplies or equipment we may be able to provide to them after we're leaving. This is a page from CyberSite. This is the telemedicine communication. After a program on the plane, when I leave, I can continue to communicate with the host doctors about the patients that we've operated on. We can also talk about any difficult cases that come up that they're going to be operating on. I've had the opportunity to return to a number of countries on ORBIS where I've been there on a previous ORBIS program. And it's very gratifying to go back and to see the quality of ophthalmology care improving in that country as a result of that relationship with the host doctors with ORBIS. In 1988, when I first went out on ORBIS, there was legitimate debate among public health experts about whether modern eye surgery should be taught in the developing world. There were very many smart people who thought that it would not be cost effective and thought that we would never reach the point where we had an adequate number of skilled surgeons to be able to do this work. ORBIS was a leader in the early 1980s in teaching modern surgery in the developing world. And when I first was out on ORBIS, I knew we had something good, that we were doing the right thing. But in my wildest dreams, I never thought that in the ensuing 24 years that we would see the quality of ophthalmology care in the developing world improve to what it has today. ORBIS has had a dramatic impact on helping prevent world blindness. We are not where we want to be yet, but we are on the right track. Thank you very much, and we'd be happy to answer any questions.